There's a lot that goes into hair loss and a preponderance of diagnoses you could consider. But at this level, the MS3 level, doing dermatology, there's only about 5 diseases you need to know. We're going to go through an overview or an approach to hair loss and not get lost in the details, and then cover the 5 you need to spot. And you need to spot them based on their location and the hair growth. Let's start off with that approach. So someone comes in complaining of hair loss, and this is really going to be for you not to use it clinically, but as you read textbooks about it. The first branch point is it intrinsic or not? An intrinsic hair loss are going to be genetic components that weaken and make the hair not as good. Don't learn any of those diagnoses, but when you read about it, you might encounter them. And there's extrinsic. In extrinsic, you're going to have scarring and non-scarring. Scarring is also called cicatricial. Don't memorize the word. That's for dermatologists. Non-scarring is the other one. In the scarring type, it's going to be inflammation. And the type of cells that are involved are going to determine subtypes. And that's all you need to know. Because the diseases that we're going to cover are those that are non-scarring and have nothing to do with the hair themselves, extrinsic influences that cause hair loss. These are the ones that are the most common or have a very clear pattern that you're going to get in a simple vignette. That's going to be androgen alopecia, male pattern baldness, alopecia areata, an inflammatory disease, tinea capitis, fungal infection on the scalp, trichotillomania, and traction alopecia. All right, let's start off with male pattern baldness, androgen alopecia. Post-pubertal androgens are designed to turn off hair follicles. And the thing that's implicated the most is 5-dihydrotestosterone. What happens under the influence of this hormone, hair follicles miniaturize and then become very friable and fall off. What you're going to see in the way of the pattern is you're going to see a circular patch that grows out from the crown. It starts in the back of the head and then circles, and they begin to lose their head on the crown. Much to my chagrin, male pattern baldness is not the ascending widow's peak. This does not respond well to therapy for androgen alopecia. The patch on the back of the head, however, on the crown, does. The diagnosis is clinical, and the treatment involves minoxidil, which it works, but it's poorly understood, and because of the 5-DHT, finasteride, which turns off 5-DHT. We compare androgen alopecia to alopecia areata, which is an autoimmune destruction of the hair follicle. What you'll see is a patch, well circumscribed, but it can be anywhere. It does not necessarily have to be at the crown. And if you get in there, what you look at for androgen alopecia is essentially no hair. In alopecia areata, what you'll see is the exclamation point. It looks as though the hairs are floating in space. As the hairs get closer to the follicle itself, because they get closer to the scalp, they get thinner and they depigment as a result of the autoimmune disease. So the hairs that are floating out there are normal, but the ones closer to the scalp or begin to degrade. The diagnosis here is clinical, and because it's an autoimmune disease, you may not be surprised to find that steroids are the answer. You can use topical, intralesional, or systemic, depending on how severe the disease is. Then we have tinea capitis, and tinea capitis is a fungal infection. And I do not want you to remember the name Trichophyton tonsurans. Going for 270, that's fantastic. But just know that tinea capitis is a fungal infection. And what happens is that you're going to see a well-circumscribed patch of hair loss, but all the hairs are going to be equal in length. Now, if you've been paying attention through dermatology, you know that some fungus respond to Wood's lamps. And the Wood's lamp is an excellent tool in derm because you just shine a light on somebody and you get the answer. Trichophyton, however, does not light up under Wood's lamp, so that's not the right answer. What you want to do is get a KOH prep to see the fungus. And here's where the test is going to get you. Tinea capitis is the only fungal infection of the skin where you start with oral therapy. Oral grisofulvin. You don't use topical, you use oral because if you don't treat it, they can actually have permanent hair loss in the patch that's infected. Next is traction, alopecia. This is actually when someone pulls their hair too tight. And you're going to look for a woman. It can happen in men too, but the vignette likes to go with women because women usually are the ones who braid their hair and go into ponytails. And so if you pull it really, really tight, you cause traction alopecia. If you cause traction alopecia, it is too late, the damage is done. It's a clinical diagnosis, and while it is preventable, it is not treatable. So once they have the alopecia as a result of traction, it is irreversible. 2 left. Trichotillomania is essentially a disease just like OCD, but is also associated with PTSD and major depressive disorder. In this case, again, it's going to be a woman who pulls on her hair. This is sort of a compulsion to relieve some obsession. Some stress induces the need to pull out the hair, and she may not even know she's doing it. So look for a woman who pulls out her hair. And the thing is, because she's doing it one strand at a time, you might notice that the hairs are in different lengths. And if you shave a patch into her head, all the hair follicles are going to grow at equal lengths. Because these are too small to grab onto, that patch is going to grow back normally, even though she's got pieces of hair missing all over. The diagnosis is clinical, and the treatment is more OCD than it is anything else. You're going to have to put her on medications and get her counseling to control the compulsions and control the anxiety. Now, I didn't include it up here on our approach, but you should also know about chemotherapy. People who get put on chemotherapy lose their hair. This makes sense because chemotherapy goes after rapidly dividing cells. And it can't distinguish between normal good cells that are rapidly dividing and the cancer cells. So you get nausea and vomiting because the gut epithelium rapidly divides. You get bone marrow suppression because the bone marrow rapidly divides. And you happen to lose hair, your hair falls out, because hair is rapidly dividing. It's always growing. So when you get put on chemo, be prepared to lose your hair. Because that's so obvious, this is where the test might go take a step back and try to get you on some step 1 activity. So let's review the hair cycle and understand what might happen when you go on chemo. It all begins with anagen. This is effectively the growth phase of hair. Usually, it lasts years. Catagen is the phase of regression. The hair is still hanging out, but the follicle is going away to start building new hair. After catagen is telogen. This is the resting phase. The hair is just out there. And then exogen, which is the shedding. And as the hair sheds, new hair follicles underneath have already begun anagen to resume the cycle anew. What happens in chemotherapy is one of two things. Anagen effluvium causes damage to the hair follicles so they become very light and easily come off. So you just touch them and they're gone. Anagen effluvium essentially takes the growing hair and puts it into the shedding phase. Telogen effluvium takes that same growing hair, the ones with lots of cell division, the anagen phase, and pushes it into the telogen phase, taking the hairs that's too small and essentially rushing it through the cycle. So they're kind of the same thing. The hair falls out, right? That's exogen, that's the shedding. But anagen effluvium is to making the hairs really weak, and telogen effluvium is exiting the growth cycle too soon. In chemo, you lose all your hair. You're not going to miss that. What you need to do instead is be able to compare the other 5, which is why I included them in our approach, so that you can identify what the picture will look like. Androgen alopecia is a circular patch on the crown of the head, no hair. Alopecia areata is a circumscribed patch anywhere with the exclamation point because the hair follicles depigment and get narrow near the scalp. Tinea capitis has well-circumscribed patch with all hair at exactly the same length. Traction alopecia occurs in a woman who braids or puts her hair in a ponytail too tightly over a long period of time, and trichotillomania is going to have patchy alopecia all over the place with the hair in different lengths. That's alopecia.